It's my pleasure to welcome you guys to this evening's Public Health Grand Rounds. It's our inaugural session. For those who don't know, I think I know most people here, but I'm Renard Washington. I'm the Public Health Director here in Mecklenburg County. And I will get us started this evening first by introducing my co-presenters and panelists. I'll also tell a little bit of context about what Grand Rounds is and what we hope it to become in the community, as well as and kind of why we are here this evening. And then I'll share a little bit of a high level overview of the topic for tonight, which is, of course, increasing access to primary care in Mecklenburg County. So, again, let me just say thanks to the team before we get started, the team at the APHI for all the support and work to coordinate this evening. And make sure that we were able to have all the necessities to be able to have a productive session. So, thank you to Julie and to Mike and all the support team from the health department who have made this possible. So thanks to everybody, and I'll thank you again before we leave. Let me just jump in and introduce our speakers because I'm very excited to have them all here tonight to talk about this very important topic in our community related to primary care access. This is me. I won't talk about myself. Uh, but I'm going to get these introductions out of the way and I'm going to keep them brief. You guys have a program that has a summary of everybody's credentials and what they do. But Ms. Carolyn Allison is who my immediate right here, who's the Chief Executive Officer for Charlotte Community Health Center, which is one of the two federally qualified health centers that we have here in Mecklenburg County. She serves as the Chief Executive there, running all the day-to-day operations and does a fantastic job serving our residents in the county. Next is one of our team members of the health department, Miss Keela Marlin. Whoop, whoop. Uh, she's going to kill me after this, but she is our Community Health Worker Initiative Program Manager, and Keela had joined us several years ago to really build out infrastructure for us as a county and a community to be able to have community health workers who are supported, connected, and working to impact the life of our residents. And so we're very proud to have her here this evening. Next, Miss Jennifer Snow, who is the Vice President of Community Health at Advocate Health, formerly known as Atrium Health. Jennifer is a wonderful community partner for us in the work that we do to improve population health in Mecklenburg County, not just on the access to primary care front, but also as we do our work to address the social needs in the community. And so really appreciate her partnership and look forward to hearing about some of the work that one of our biggest health systems is doing here in the community to make sure our residents have access to primary care. And finally, Dr. Michael Doolin, who is the executive director for APHI, as well as a professor at the university's Department of Health Management and Policy, who leads the APHI, champions the APHI work, has been with us since the beginning or inception of APHI in a leadership capacity, and does a lot of fantastic work both in policy research, is a physician himself, and still sees patients in the clinic, and has been a great partner for us in conceptualizing and making tonight a reality for us. So with that, what is Grand Round? So our vision for this is really an opportunity for us as public health practitioners, academics, students, community members to come together to talk about issues that really impact the public's health. So what we envision over the next several years is providing an opportunity at least twice a semester during the academic year to have these kinds of sessions in the evenings for both our residents, again, practitioners, researchers, and folks who care about the critical public health issues. So tonight we're talking about primary care, but we will be covering all the topics that are in our community health assessment, as well as any relevant topics that community members want to discuss in this session. And it really is meant to be interactive. So the format that you'll see tonight is what you'll see at all these sessions. We'll have a panel. We'll provide some context and some presentations. We'll talk for just about 5 to 7 minutes apiece, and then it will be open discussion. So I'm going to moderate this evening, but I don't have any questions. So my charge to each of you as you're listening is to think of a question, and we're going to get to many of those as we can. And what we're looking for here really is an interactive discussion about how we can do a better job collectively, both again, those that are in practice, our elected officials, and others, to improve the health of our residents here in Mecklenburg County. As many of you all know, access to primary care has been a very front-facing priority for not just the health department, but for us as a broader community. It is a priority for our Board of County Commissioners, and so we continue to prioritize making sure that our residents have access to primary care services in the community. It is fundamental to being able to stay healthy. There are so mmany benefits to primary care, but too many of our residents either can't afford to access primary care, don't access primary care, or can't access it. And so it does impact their ability to live a long, healthy life. There's so many benefits that are well documented in terms of what the benefits of accessing primary care, both in terms of preventive health, early diagnosis of disease, managing chronic illnesses, as well as helping to avoid unnecessary use of hospitals as well as emergency departments for things that can be resolved in the community. And so as a result of that, it continues to be a top priority for all of those constituent groups that I described earlier. When you think about access to care, there are lots of reasons why people don't access primary care, and I always try to explain this to a lot of folks. You know, why don't people go to the doctor? Right? It sounds so simple, right? Like just go to the doctor, right? But there are a number of reasons I think that many of you all can recognize that drive whether or not people are able to access care. That includes their own decision making, which might be driven by the social context in which they live. It also is impacted by the structure of the systems around them. So, do they have doctors in their community? Can they make an appointment? Or is a 6 month wait time for a primary care appointment? Can they afford to pay for it? Is there, come on in. No, you're all good. This is it's a casual session. You're all good. I should probably not moderate anymore. I'm going to embarrass too many people. Availability, affordability, and of course, is it appropriate? Are people receiving the kind of care that they feel comfortable to go to, that they feel like they can be honest and transparent and actually get a level of care? And all those things either result in a person having access or not having access. In Mecklenburg County, we do a lot of work to expand access to care. We have a number of providers who are helping us in this work. As many people know, the health department doesn't deliver primary care directly, but we have a whole network of low cost clinics who are doing fantastic work to expand access. But there are still too many of our residents who don't have access to care or who are not accessing care that is available to them. And so we have more work to do. Last year, as some of you all know, it looks like the formatting here got a little bit messed up, but we released 2 years ago an Access to Care report that had some really critical recommendations around key areas for intervention in the county. And some of those involved reducing the number of people who don't have insurance, increasing the capacity of our current system, which we're going to hear some more tonight from our providers about what's happening in that space. Also, the need to educate patients on the importance of primary care and help them navigate to it, which is why we have Keely here to talk about how community health workers might be able to play a role in this. And then, of course, just increasing awareness of what is available to people, where can they go get care without the burdens of some of those issues I described earlier. And I think I'm going to close here with where we're going for the evening, as this is the work of a large group of individuals. There are lots of partners who have a hand to play in our ability to address this issue. And I look forward to hearing from not just our speakers, but again from each of you about what ideas, thoughts, criticisms, positive things that we're all seeing in the community that might help us continue to move the needle forward in making sure residents are able to access preventive care. So with that, I'm going to turn it over to Carolyn and let her take the mic for a bit, and we'll be back right after that. And actually, I'm going to let all the speakers just come on up afterwards, and then we'll transition to the Q&A.
Thank you, Reynard. Welcome, everyone. Thanks for coming out this evening. Really appreciate that. Carolyn Allison, CEO for Charlotte Community Health Clinic. And I'm just gonna, do I just touch this or? There we go. All righty, I'm gonna go, there we go. All right, pardon? The other way? There we go. All right, with you. In the beginning, when we started as a free clinic, and that is very unusual for community health centers. We started from a dream, from a vision from Dr. Ophelia Garman Brown. And I always like to bring reference to her because she was truly a very strong, very mighty person in this community and really helped many of us to galvanize ourselves around access to care. She started the free clinic, Charlotte Community Health Clinic, with the assistance of Novant Health in 2001, along with other individuals who worked alongside of her. In 2015, the board of directors decided to apply for a federal grant to Health Resources and Services Administration. And of course, if you work long enough within the government, everything is abbreviated, right? So we call it HRSA, HRSA. And HRSA actually funds community health centers across the country. Here, as Raynard said, here in Charlotte, there are 2 community health centers, C.W. Williams and ourselves, but also there are other community health centers that are coming into the community. Cabarrus Rowan Community Health Center has a new site, or will have a new site here. We also have what's called a look-alike community health center. So you'll begin to see some more what they also call federally qualified health centers. I'm gonna move forward. We currently have 3 locations. We are located in East Charlotte, also West Charlotte, and in the North Charlotte area, University area. We are planning to open one more new site. We opened one additional site in February of this year in partnership with Thompson Child and Family Focus. Thompson Child and Family Focus, they are a behavioral health organization serving children. One of the ideas that we had as a team was to actually embed a pediatric clinic within their location. So when parents go to take their children for childcare, et cetera, around behavioral health, they'll have access to a pediatrician if they need that type of access. We also we're in the process of opening another site, our third site that will be opening. And that site is in partnership with 2 other organizations. You'll learn later in my presentation that we provide services to a population that is about 60% Latino. And so we partner a lot with other organizations serving the same population. We'll be partnering with Outreach for Kids. They provide after-school programming and other services for immigrants and refugees, and also Carolina Migrant Network. They provide legal services for immigrants coming into the community. We will be building this multi-resource center on the campus of Aldersgate within their administrative building. We already broke ground for that site, and I'm really excited about it. And this will be a site for immigrants and refugees to come into the community and have access to medical care, have access to legal care, and also after-school programming in one location. And this is actually a model that will be here within Mecklenburg County. I listed out many of the different services and programs that we're offering. Community health centers were unique in the sense that we see both individuals who are uninsured, but also insured, people on Medicaid, Medicare, and also private insurance. We really want to focus on those individuals who are underserved. And so that's what our focus is. So our programming, we are required to offer 3 core services as a community health center. That is primary care, medical, behavioral health, and also dental services. And I'm proud to say that we offer all 3 at our sites. We offer, as I indicated, adult medicine, pediatric services. I won't read through the entire list. I'm very grateful to Mecklenburg County because in the health department, we were able to get a Ryan White grant. So we're building out a Ryan White clinic for our community, and that's located in our West office. And we're embedded within the Good Opportunity campus on Wilkinson Boulevard. So if you've ever been to Goodwill and you see the medical clinic there, that's our clinic. And also our dental clinic is located in the same area. We also have a partnership with Roof Above, Healthcare for the Homeless. Part of our federal grant is for us to serve the homeless. And also, once again, part of the money, the funds that we receive from Mecklenburg County is for us to provide care for the homeless. So we have a full-time nurse who is at both of their locations, Urban Ministry and also the men's shelter. She's 2 days a week at one site, 2 days a week at the other site, and she is their nurse. So they have immediate access to that type of care. If those individuals need access to more care, they're referred to our other sites. And so we have that kind of relationship and referral process. We do offer pharmacy services too. We have a partnership with a local pharmacy in town, a retail pharmacy, but also, once again, I keep saying Mecklenburg County, has also funded us to be able to build an in-house pharmacy. So we'll be expanding our pharmacy services. Medicis is here. We are still partnered with Medicis because many of our individuals, about 68% of the patients we serve, are uninsured. So we need Medicis. But also other individuals who we serve are, like I said, on Medicaid, Medicare, and also private insurance. So this expansion will help us to provide that kind of services. The population we serve, they have to, many of you know, they have to take buses, depend upon, relatives, friends, in order to get to their appointments. So it's not that easy. And our job is to break down those barriers. We do have an insurance navigator on site, and that individual actually, she works with individuals, our patients, who do not have insurance, but they do qualify for the Affordable Care Act. Some people know it as Obamacare, and this is a real great opportunity for individuals who are uninsured to get access to insurance. And also community health workers. Can't forget them. This is just an outline of our population. The federal government, through our grant that we received from HRSA, Health Resources and Services Administration, they require all community health centers to provide data every year. That data is based upon a calendar year. And so we just submitted our data to the federal government in February. On February 15th of every year, community health centers must submit this data, and it's called a UDS report, Uniform Data Systems Report. It covers demographic information, medical information, and also financial information. This information is rolled up to the federal government and also passed on to the White House so that they have statistics and data on programs that they're funding at the federal level. So it's very important. But also at the local level, this data helps us to make sure that we plan for programming for our community. So in 2022, we served about 5,600 total patients. Year to date, well, I won't say year to date, but in 2023, we served over 6,000 unique individuals. When I say unique individuals, we count one person at a time, not how many times you come for your visit. But you can read this information and see. Also, I shared about the ethnicity. We have a large Hispanic Latino population that we serve. And why is that? Well, when Dr. Gorman Brown started the clinic, it started in East Charlotte. And as you know, East Charlotte is a very multicultural area within Mecklenburg County. We were very fortunate as we started moving the clinic to other locations, our population, our patients moved with us. And so we still have a large population of individuals who speak Spanish, and their origin is from Spanish-speaking countries. We decided all of our front desk individuals, when they check in for an appointment or you call for a visit, they're all Latinos, Spanish speaking. So we want to make sure that barriers to care, if we can do anything to reduce, once again, those barriers to care. We also recruit for individuals, providers, nursing staff who are bilingual. But we want to make sure too that we're serving a very diverse population. We have a pediatrician who's Vietnamese. We have people coming from various different origins, countries, and also language backgrounds. These symbols are awards that community health centers are recognized under because of the quality care. And so if you really leverage your IT system, if you're providing highest quality of care, these are different types of recognition that HRSA provides to community health centers. How do they determine it? They look at that UDS data, and that's how they determine it. So it takes a lot of work for us to really focus on providing high quality primary care. And they don't just kind of give this out, you have to work for it. And we're very proud of it. PCMH, many of you may know, Patient-Centered Medical Home. I talked about the in-house pharmacy. And we're building out this in-house pharmacy at our Medical Plaza location, which is located on Harris and also Mallard Creek. We're on the third floor there. It's a Novant Medical building, but we're not owned. We can't be owned or operated by a hospital system, but we do partner with both of our systems. And so we're in that location on the third floor. We're hoping that this pharmacy will be completed later this year. We are also very grateful once again to have received the opioid settlement grant funding from Mecklenburg County so that we can expand our services and assist individuals with substance use disorders. And this is going to be very, very important for us and also with our community partners. And then I spoke about the Ryan White Clinic. We were able to bring on board a physician who actually has over 20 years of experience, who set up a Ryan White Clinic at one of the local hospitals, and she is now working with us to help us build out our Ryan White Clinic. And so we're really, really excited about this. This program is passionate for me because I have to share with you, my oldest brother passed away from AIDS back in 1990. And so I've always wanted to do something like this, and forgive my voice, but it means a lot to me. And this population, like all populations, need the services. And we are here to partner with the health department, whoever else wants to hold our hands and get it done. Thank you, guys. Thank you.
Okay, now I have to follow Carolyn. I don't know how to, we'll see how this goes. Okay, so as Raynard mentioned, or Dr. Washington mentioned, my name is Keela Marlin. I am the Community Health Worker Initiative Program Manager at Mecklenburg County Health Department, and I will be talking about community health workers. So, community health workers, oh, the words are not showing up. Joy. Okay. So, a community health worker or a CHW is a trusted member of or has an intimate understanding of the community served. And this is either because they share the same cultural background of the community or they share the same lived experience of the community. So, as Carolyn mentioned, her brother had passed from HIV. And so, something like that, a community health worker would be ideally fit just because they understand the needs and the experiences of that community. Also, a community health worker can speak the same language of that particular community. So thinking about the Spanish speaking population or thinking about another indigenous population where the languages may be varied. So they also serve as the link between health and social services, and they do this by facilitating better access between those two sectors to make sure that residents and individuals and communities get the help that they need. So the community health worker term, it is an umbrella term that includes a bunch of different titles. So you have community health representative, which is indicative to the indigenous population. So most times you'll see that title on Indian reservations. Then you have promotor de salud, which is indicative to the Spanish speaking population. And then you have care coordinator, patient navigator, outreach coordinator, community connector, all the names that community health workers are called, which really makes it hard to identify within the workforce because largely these titles are contingent upon what the organization chooses to call them and the work that that community health worker chooses to do. So a community health worker helps achieve health equity by doing and core roles, which you cannot see listed. So, according to the CHW Core Consensus Project, or C3 Project in short, they did a mixed methods approach to where they did a national survey, basically asking community health workers, what do you do and how do you show up in community? And those were 10 roles that you'll see on the Mecklenburg County's website. So the 3 roles that I wanted to highlight out of the 10 was cultural mediation, service coordination and navigation, and then patient education and information. And so I'm going to read from my notes to make bring some meat to this. So one way that community health workers help facilitate access to care is by doing service coordination and navigation. And we've seen this a lot during COVID, particularly when community health workers were referring clients and communities to food banks or housing, um, vouchers to make sure that their rent was paid. And so they possess the unique ability to identify and access resources by overcoming and or removing barriers. And then they also make appropriate referrals based on the client's preference. And that's important because a lot of times, we'll go into a provider's office and, they'll suggest us one thing and we may not want that, but a community health worker recognizes that that's something that the client or the patient may not want. And then they also are able to identify if that's feasible or not based on that client's living condition. Also, community health workers are able to follow up and track to make sure that the client or the community member receives the care that they need. Too oftentimes, our community health workers, well, not our community health workers, our residents within the community are missing the services that they are referred to by their providers. And so community health workers are making sure that the client receives the service that the provider has referred and the service that they need. Another way community health workers can facilitate access to care is by providing culturally appropriate health education and information. And again, this was done and demonstrated during COVID as well, where community health workers were on the front line, whether they were disseminating out COVID test kits, sometimes giving vaccines as well, but mainly making sure that the community understood why it was important to receive the COVID-19 vaccine. And I played a big role in that in my previous position. And so community health workers, they educate individuals and communities about how to navigate health and social systems. They also conduct health promotion and disease prevention education that matches the needs of that individual and community. And then they build on the health literacy that that client or that community may have. And so they do this by communicating across cultures to ensure that there's a genuine understanding. And it's a known thing within the CHW workforce that we're code switchers. So like I'm up here having this conversation with you, I can also have another conversation with somebody in the streets, So the current market for community health workers is high. So according to the U.S. Department of Labor, they estimate about 8,000 positions will open each year. And this is much faster than the average occupation. And so then the question then begs like, well, are they really impactful if they're growing like this? And so, oh, yay. Yeah. So, and so, there's literature out there that demonstrates that community health workers are impactful and is finally demonstrated on the slide. But I don't want to bore you so much with the evidence-based literature. I just want you to take away that community health workers are known to reduce health disparities. They're known to improve population health, and they're known to advance health equity. And so I want to conclude with what Mecklenburg County Public Health is doing. Many of you may know about a guided journey, but what we do largely is partner with community-based organizations and health systems to facilitate access to care. And a guided journey was one of those first steps. So a guided journey was implemented in 2021. And this is a program that serves pregnant women in those 90 days postpartum to link them to prenatal postpartum care and also supportive wraparound services. And Caring currently facilitates this program. Also, the Community Health Worker Initiative in 2022, we've been leading collective impact work groups. And so the first is the Stakeholder Advisory Collaborative, which is a network of organizations that lead, employ, and educate community health workers. So right now we're up to 10 organizations that make up that collective. And then we have Queen City Community Connect Coalition, which is a network of community health workers in Mecklenburg County that serve. So With those two work groups, they create a sustainable infrastructure that supports and values CHWs. And this has never happened before in Mecklenburg County and was so desperately needed. And based off of the presentations that we did last year, we learned that we are the only health department in North Carolina doing this. So the last thing I want to add is that most recently Mecklenburg County Public Health acquired 2 mobile units. And that is largely to support some of the work that we're doing out in the community. And, just added on bonus that this is another excellent way we can operationalize the community health worker model by facilitating direct service and community outreach. So thank you.
So good evening, everyone. As Dr. Washington shared, I'm Jennifer Snow. I'm the Vice President of Community Health with Advocate Health, which Atrium is now a part of. And this evening, I'm going to share a lot about our equity and access strategy that we deployed in the Southeast. Most of what I'm sharing is all from our Southeast model that was part of our community and social impact strategy. And we're in the process of figuring out how to scale some of these best practices across the entire enterprise now. So thinking about equity to access and what that means. For us to be able to ensure equity and access, we have to be able to look at what does that mean and what are we doing to really measure or even measure if we are having equitable access. And this is really a three-pronged approach. So we have to look at availability. And what does availability mean? Not just appointments, but do we have an adequate supply of providers? Do we have an adequate supply of practices and clinics? Do we have enough practices and providers that actually accept patients that have Medicaid or are uninsured? And these are all things we're looking at when we look at what availability looks like. Accessibility is another core measure of ours, and accessibility is more around looking at our access points. What does that look like? And we measure things. Do we have walk-in appointments? Do we have same-day appointments? What does it look like from the policies that we have? How do we have our proximity to urban areas? Do we have practices within 3 to 5 miles? We have to look at rural access measures. And then we have acceptability. And this is really focusing on the quality of care that we can provide and really ensuring that access is not only equitable and high quality, but are we able to look at clinical and safety measures? What are our health equity gaps? Are our providers and teammates trained in cultural competencies and best practices? And this is really our approach to how we define and focus on equitable access. So recognizing that we have to take care beyond traditional practice settings. We can't just wait for patients to show up anymore. And traditional practice models don't work for everyone that needs access to care. We've really developed a model where we're looking at taking care into the communities. And this recognizes not only do we have to think about things differently, but how do we deploy technologies? Do we have availability in non-traditional hours? Are we looking at meeting patients and community members where they live, work, pray, and play, whether that's a community-based virtual clinic or taking a mobile out? And then are we really taking care into the homes through hospital at home programs, through our community health worker models, and also just looking at best practices in general and ways that patients and community members want to engage within access to care now. Another core part of this has also been actually looking at our policies internally and how are we supporting patients in our financial assistance programs and charity policies. Do we have best practices around when a patient can't get to an appointment? Are we going to discharge them from a practice? And is that equitable? And so we're really taking a holistic look at our policies internally to really drive equitable access. And some of you may be familiar with some of our community clinic models that we have in the Southeast, and a lot of them are in Mecklenburg County. So in addition to our traditional practices, we have a community clinic model where we have built practices in communities that need access to care, have high emergency department utilization, and really trying to look at what the practices look like, but also making sure that they have support services embedded in them. Do we have RN, so nursing, social work, care management? Do we have community health worker models? Are we screening patients for social drivers of health and then able to actually help them get connected with the community-based resources and partners that they need to help improve that? Just recognizing that a traditional practice might not be everything that a patient and their family might need. And these are where looking at, you can see on the side, our footprint in that, looking at the greater Charlotte area. Just opened Ed Brown Community Care Center last Friday, and then last year opened Archdale. And we're continually looking at where do we need access and what do those measures look like? And this requires a data-driven approach to this work and really thinking about how we look at where needs are and what that could be. And so when we look at how we look at access, and these are traditional brick and mortar practices like you just saw in the community clinics, but also our virtual clinics, and where does our mobile go? And so we're looking at a combination of all of our public health data, whether it's data that we use in the community health needs assessment planning, but also our internal electronic health record data. Where do we have patients that aren't getting primary care? Where do we have patients living that have higher disparities in their gaps in care closures? Where do we have the highest emergency department utilization that could have been avoidable if someone would have had access? And so we heat map that data, and then we have limited resources to open new practices. How do we prioritize the communities that need that access the most? And the clinic that just opened at the Stratford Richardson Y is the perfect example of a partnership that was developed in a community that didn't have access to care. And so we take this approach to when we look at capital restraints from opening new practices, as well as our community virtual access points. And something to highlight that we're continuing to look at, and if you look at Mecklenburg County in general, and just changes in what was formerly known as the Crescent and our high priority communities, they're changing. And so keeping an eye on this data and where the highest needs are is going to help us. We may not be able to move a building very quickly, but we certainly can deploy virtual clinics and mobiles in that way. And that's a big part of our equitable access strategy, and just looking at how communities are shifting. We're doing a lot of work right now with our University City emergency department. They now have more non-emergent emergency department visits than CMC, and trying to figure out how do we support with access points in community and look at things as they evolve and shift. And really excited about this data-driven approach and really being able to move resources around as the needs change in community. And then I want to highlight our mobile health clinic program. We have launched in the last 2 years 5 new mobile health clinics, mobile primary care, and then also our Drive to Thrive unit, which is a mobile women's unit, and really trying to focus on taking care into community. The mobile primary care units look just like a family medicine practice with a nurse practitioner on wheels. And we're going out, we're able to see patients and anyone in the community that doesn't have access to care, services that you would get at a traditional family medicine practice. We try to see those 2 and up, but if a child under 2 came in with a sick or urgent care need, we could triage that. We do try to make sure that infants and any child under 2 gets connected to a primary care provider and pediatrician for their well child visits, just because that's harder to manage on the bus, but we always do that entry point and make that connection. But on the mobiles, they operate just like brick and mortar. We deliver basic acute and primary care services. We can diagnose, treat acute and chronic illness, prescribe prescriptions. We also do our social determinants of health screening there on the bus and connect them with community partners resources, community health workers for follow-up. We can work with vaccines and boosters as needed. Looking forward to hopefully partnering with some of the dental programs to be able to do dental alongside with the county and some primary care, but really trying to make sure that we're offering real-time walk-up appointments. And our mobiles were deployed during the vaccines with COVID and the pandemic. And one of the things that we saw is that most of the patients coming to the mobiles for their vaccines versus the stadium or another practice where they could get access to a vaccine, being able just to walk up and not have an appointment and not have to register an email address or sign up or answer all those questionnaires just to get real-time access when you could get to the unit was so powerful. And that's what we're trying to do, is remove the barriers to access to care with the mobiles. Also, our community-based virtual clinic sites work the same way. They're a walk-in model. So the ones that were deployed in over 150 schools, large partnership with CMS schools, and really looking at how we can make access to care in schools with a telepresenter model that's real-time available, not only for students, but also teammates within the school. And so the employees have access to that as well. Those are walk-in models, and seeing a lot of success in those as well. Just not having to have an appointment and not doing, having to do all the pre-work. So making it readily available, convenient in community is a core part of our strategy. And then on the acute social needs side, I do just want to highlight, rolled out this year, we have now rolled out over the last 9 months, consistent social determinants of health screening. And we're continuing to add community-based partners to a tool that we use. It's called the Community Resource Hub. Novant also uses the same tool. And then we're partnering with community partners to take referrals. But we're continually trying to figure out how we connect at the point of care our patients with the local community resources that they need. And it's a big component of the work that we do, and looking at, if I had to choose between feeding my son or getting medications for myself, I'm always going to choose feeding my child. And we're really trying to look at that upfront at the point of care of what can we support you around, and making sure we're honoring the patient voice in that. Screenings now are required for every single inpatient admission. So at a national level, CMS is now requiring that. And so we're asking these questions, and we're doing a lot of work internally, not just on the equitable care that I talked about and cultural competencies, but how do you ask these sensitive questions and make sure that the patients and our teammates feel supported in that work. And so we're working on the mobiles to implement some best practices on that, but continually trying to better connect our patients to the social health needs that they have. All right. And next, I'll hand it over to Mike.
Thank you very much. Excited to be here this evening. Mike Doolin. I think my official role was to provide the boring evidence-based academic viewpoint tonight. But fortunately or not fortunately, I've been a primary care physician in the community for about 20 years. So it's a little evidence-based, but a little bit anecdotal on my 20 years of experience doing research around access to care and primary care. So it's hard to follow Reynard. I think he caught all these already, but primary care is kind of like baseball and apple pie. I mean, everybody's better when you have it. Well, maybe, I don't know, baseball's okay, right? But anyway, it does make everything, it helps pretty much across the board. Life expectancy, access to cancer screening, access to behavioral health. I should highlight, over half of the visits that come into primary care to see me are related to behavioral health in some way. But I think most importantly, access to care can help reduce health disparities and health equity and advance health equity. So really something for us to think about, and particularly as we look at things like maternal health and needs for advancing maternal health, particularly for the African-American population, access to primary care improves outcomes, maternal health outcomes as well. Something to really think about, because primary care is where a lot of people have access to contraception, prenatal vitamins, those types of things to really help in that domain. Some of the barriers to access, and I'm going to comment a little bit on the work that was done here in Mecklenburg County, but by far and away, the biggest barrier to access is trust. People not trusting the healthcare system, not comfortable going in, not knowing how to navigate how to navigate the healthcare system. And I'll just ask those of you in the audience, how many of you, when you made your decision about your primary care doctor, ask a friend? Most of you? And that's true of us. It's also very true of people that are facing adverse social determinants. People that have to navigate the healthcare system often rely on their network to make a decision about where they go to get care. Cost is the second. And even when I was working in the community clinic, even a $3 copay was sometimes enough to turn someone away. They'd show up at the clinic, they'd take the 2 buses, find daycare, come, and the $3 was enough to break them and say, no, I'm going to go to the emergency department instead. Other barriers were much less of an issue after you overcome trust and cost. So transportation, the hours and availability, the things that have been talked about here. One of the things I found in this community, we were interviewing people about use of primary care versus emergency care. And people loved emergency care a lot of the times because it was available. You work 2 jobs during the day, you get off, your primary care doctor is closed. Let's go to the emergency department. There's no copay there. You get taken care of. You get a lot of tests, which means that, they're doing a good job taking care of you, right? The language and cultural barriers came up over and over again, and that's really feeds into the trust as well. If you show up in a clinic and your culture is not respected or understood, you're going to not trust that place and not want to go back. And then the perception, and again, I mentioned about my emergency care being better. So the interventions, what works? Well, setting up things like Carolyn's Community Advisory Board, having community members or patients actually serve on the board and having them be a voice for the clinic and working out in the community and saying, this is an okay place to go. I trust it. I feel comfortable there. You should go there as well. Overcoming that barrier and getting out and getting into the social network in some way, creating that trust so people feel comfortable. A lot of times in primary care, and I was guilty of this when I started my career too, we like to lock ourselves away as primary care doctors. You're lucky to come see me. You have to come through those double doors in the front. You have to make a copay. And they're like, who is this guy? Why should I trust him? When doctors get out in the community or community health workers get out or peer health workers are out there saying, this is a place you need to go. You can trust it. You need to have access to this care. It can improve your outcomes. That makes a huge difference. And I'll show you an example with a map that's just about a decade older than Jennifer's. I didn't have the same technology a decade ago that you have today, Jennifer. Geographic location is really important as well. Having something that is in your community that you trust. When I started in the community clinic at Atrium, it used to be there in Myers Park. So you have to take 2 buses, but you would end up in a community that wasn't really your community, where you didn't feel comfortable. Again, the after hours care, using telehealth or other ways so people can get into care when they need it. The integrated care models, I think, is also extremely important. So sometimes as a primary care doctor, I'm not able to provide the behavioral health care needs, the complex needs of the patient that's coming in my clinic. But if somebody a partner is there, a social worker, a psychologist that can help to do the warm handoff, makes a huge difference. There's less stigma coming into primary care to get behavioral health. And it's super easy for me. I can say, let me introduce you to my colleague who can help you more with the social need or help you with your behavioral health need. And then you get to meet somebody, you can say, okay, I'll come back next time and be able to see that same person. And the same is true of nutritional needs, having an embedded nutritionist and other pharmacists, other services right there in the primary care location makes it a lot easier and better for people to get access. And I put this last, but it may be the best, the community health workers and lay health advisors, as people that are getting out in the community, making a difference and helping to guide people and get them into healthcare. And it's so tricky. I'm dealing right now with navigating the healthcare of my mom. And, I'm a healthcare provider. I've been doing this for years and it's super complex. I mean, it takes all my time sometimes just to help her, get the doctor's appointment, make sure that her notes get from one doctor's appointment to another. And those community health workers are out there doing exactly that, right? Helping people to understand how to get into care, how to navigate it, and not to be afraid of the process itself. So last, I'll show you this map that I promised, decade-old technology. My apologies. Maybe you can see it. That's Mecklenburg County. This is a map of North Carolina, so you know where it is. And this is where I used to work, that little cross up there. I used to work across from Eastland Mall, which that's not there anymore, right? So, but the clinic was there, and the idea was to get a clinic embedded out in the community of need. So a lot of people that lived in that community needed access to care. But what you can see, the red area, that's the service area for that clinic. So it was moved from Myers Park out. It was actually right next to CCHC. We were neighbors back in the day. I got to work with Nancy Hudson and others in that clinic. And you can see there's a huge problem, right? That clinic is not serving that location at all. So what did we do? Well, we started with the social network component. We got a community advisory board going. We got a patient advisory board going. We started doing community outreach. I started getting out of the walls of the clinic and meeting people in the community, walking across the street, and interacting with Latin American Coalition and saying, hey, there's a clinic across the street. And sure enough, it's pretty obvious, but within 6 months, you can see that service area changed pretty drastically. So we started actually providing services to the people that lived in the community that needed it. So just that social network component by itself, not with the other components, we weren't sophisticated enough to have community health workers then, but just that start is enough to start to bridge that trust and bring people in, and help them feel more comfortable getting primary care. So thank you very much.
All right, let me get these microphones on. Let's who am I gonna embarrass now? Gwen, good to see you. Can you help me? Uh, I'm gonna let you cover this side of the room and I'm gonna do that side.
Absolutely.
All right, I know everybody has a lot of questions. Let me first again thank all of our speakers for their wonderful experience and sharing. This is the chance for everybody to participate. So questions, comments, and just raise your hand and we'll get people in queue. Keep them concise because we do want to get to the buffet that's out there.
So I'd like you address the, oh, I'm sorry, I'm Mike Kennedy, Public Health Emeritus. I don't know. I was intrigued by your mention of the word trust. And because it came across, I think it's in the New York Times today, that women are stopping using contraception based on information that they're getting through social media. And I just wondered how, in your various approaches, this whole new universe that we're working in, how you address the disinformation and the misinformation that's out there.
I guess I threw out trust, so I'll start. I think it's a really important question. I don't know that I have the answers because misinformation is such a problem now, right? But I think that is the issue. Like, where do you go to get your information? So if you do go to a trusted source, hopefully if you have a primary care doctor or a community health worker or someone that you interact with on a regular basis, you start to trust them and believe them when the data comes from them. But how does that overwhelm other things that come through your social network? How can you compel people above and beyond something that comes through like their Facebook feed or something like that? So I don't know that we know the answers, but I would say I think it's a really important area of study is figuring out how misinformation moves through different social networks and who's more susceptible to that misinformation and how it impacts public health. Because there's a huge problem there with, I had, I guess I can tell some of these stories. When I was in private practice, I had another type of provider working next door to me that would tell people not to get vaccines. And I would have kids come in and families come in, and I would have to then spend, half an hour, 45 minutes talking to them to counteract the misinformation that was being actively spread in the community. So it's a tough one, but I think an important question to think about further.
Yeah, I'll jump in really quickly and say I think I was talking to a reporter in DC a couple weeks ago, and it's one of the things that we are going to have to contend with in public health. Like, we're going to have to figure out collectively how do people get information? How do we infiltrate those mechanisms that they get information and do so in an effective manner, right? And we are the misinformation is now ahead of us by a long shot. And if we're ever going to make any headway, we've got to partner with our academic partners to help us, because those of us in practice, we can't do this all day long. We need our academic partners to kind of help us understand the sources and how can we infiltrate in a way that actually is impactful. So it's
just one other response to that. COVID taught us a lot because we had to get outside of our comfort zone, being within buildings, being within our office, and go into community, and also begin to interact with community. And when we started doing that, that's when we realized that, you know what, we need to change the way we do business. And like you said, Jennifer, and also the community health workers, we built out and created an outreach and enrollment department in which we never had before. We partner with both hospital systems and their mobile units in order to get out into community. So I think being in community starts to help to build that trust.
Okay. I wanted to build off of what Carolyn said, because I think being out in community is one thing, but then also listening to their concerns and adapting your message is also equally important. So I was actually telling Gwen this a couple of weeks ago. I was on the highway and there's this billboard that I think Charlotte Mecklenburg Police Department had came up with, and it was like, these pills are sus. And I was trying to take a picture. I'm like, oh my God. It was so good though, because that is how the younger generation, younger than me, is talking. And I think it's important to get out there and engage with community so you can hear their concerns, adapt your message accordingly, and then continue over time to build and code switch so that we can make sure we get those needs met.
I'll add just one last comment to that. And I'm really interested in what you brought up, because TikTok and then now Instagram Reels, Clemson University has a social media listening lab. And some of the stuff they've put out and researched online is really interesting, and just looking at the messages and then how you communicate it. And then how do we in public health and community health do a better job of educating? That's a conversation with your providers. Don't go off of every video you see online. And I think there are a lot of concerns around just safety of medications in general. And you see a lot of that on moving towards an all natural or homeopathic, a lot of that trending right now online. And so there's just so much content out there, it's hard to combat any of it. But really looking at some of the AI data and then the social media listening data is fairly interesting if anybody wants to go into a Google search later. I mean, there's some interesting data out there.
Thank you all. Hi, I'm Jessica Shore-Sachs. I'm a retired family physician, and I'm very impressed to hear all these things that are going on in primary care. It's really great. My question is, what do we know about what the gaps still are? How many, for instance, how many people in the county don't have a primary care physician? Who are those people? Where are they? Are they uninsured? How many of them are undocumented, and whatever else we know about them?
Yeah, Jessica, excellent question. One of the things that we're doing at the health department, and Dr. Coyle's here, but I don't see Ben. We are actually working right now to further drill down into the first access to care report, which was our first pass at reporting publicly on the state of affairs. And we have been working to add additional metrics to that will allow us to drill down even further on who the folks are, where they are, and how we might be able to use that information to drive some of the activities that our partners are doing. One of the things I'm going to embarrass Commissioner Griffin now that we have been intentionally focused on is NC Medicaid, right? Because they are a critical partner in our work to be able to make sure people have access to care. One of their accountabilities is making sure people have a primary care provider, right? And so we've been working with them to get access to some of their data so we can understand, and this is the work that Dr. Cole and Ben have been doing to help us understand who in Medicaid has a primary care doctor and has not seen them, right? Because they have to be assigned a primary care physician when they enroll in Medicaid, but if they haven't been to the doctor in 12 months, but then they have an ER visit, I mean, there should be a way to stop them, intervene before that. So that's some of the new data that we're hoping to add to the new access to care report this summer that will help us, again, provide information to drive some of the activity.
I had just another quick comment to add to that, which is I think there's a great opportunity to better understand that from electronic medical record data.
Yeah.
So finally, the policy has changed where health systems are required to expose population health data from their electronic medical record. And luckily, we have Epic fairly universally across our community. So I think it will be relatively easy for us to start mining that data from the electronic medical record and seeing who's had a visit, who's past due for a visit, who is their primary care doctor. I think that's another problem is often people that face lack housing or face other adverse social determinants may also change physicians relatively quickly. And how do you track them across? Or they may have Medicaid now, but then they lose it, or they have a commercial insurance for a little while. So when you start to use payer data, it can be very complex. But the electronic medical record may give us a better idea of the tapestry of who has access to primary care and how do we outreach to them. The issue is someone brand new to the community, you don't know until they do access care, or the people that are hidden, to your point, Jessica.
Hi, I'm Jose Hernandez Perez. I'm the director of the Latin American Coalition. Thank you for the mention, Dr. Lumen. We got engaged in the healthcare field because of COVID and worked very closely with Atrium in Novan, for everything that was done during that time. And we have continued with that partnership and started, now we have one of those virtual clinics. And so had an opportunity to work with some of the healthcare workers and try to understand the terminology and try to understand to navigate the system. And what we have found is that at the front end, the work that's being done is amazing in Mecklenburg County, and all of the different service providers are incredible. And we work with everyone. We try, because what we realize is that you have different funding models, different ways of costs, or charging or not charging. You have different services and different populations that you work with and they don't. So we help our own constituents navigate that system. But part of the challenge that we found, and it's a conversation I want to continue, is that at the front end is really great, but at the back end, for example, if there is a form to be filled out for financial assistance, the name of the form might be in Spanish, and then you click on the form for the link, and then it's in English. So someone hasn't been navigating the system from that end, right? And so, for example, some healthcare workers needed to understand some things. Even though the healthcare worker was bilingual, we were told that they couldn't translate. So it was like, okay, we have a bilingual person, but they can't translate. So it's like, I'm sorry, but this is part of the policy. The attorneys get involved, I guess. But I could tell that they really wanted to help, and I think they actually help people. Because when you have someone right there and you're talking their language, but you can't translate to help them navigate the system, it's a challenge, right? Like be an intermediary, I guess. So I would love to. I appreciate what you're doing, but I would love as an organization to continue to be engaged as you're moving forward to see how can we solve some of the barriers that we still have.
Thank you so much for sharing that, because everything is not perfect in roses. And those are the comments that we really need to hear, because we can't fix it if we don't know it's broken, or we need to tweak it a little bit. So you're absolutely right. I know years ago when I was at another practice, we hired somebody who was Spanish speaking, didn't realize the person struggled with English. And so with some of the English patients coming through was very challenged. And so really, what do we need to do? Building criteria, that we can follow so that we can ensure patients are getting what they need. But also we're putting our team members in a position where they truly can help. Thank you.
Hi, my name's Chelsea Spinner. I am a PhD candidate at UNC Charlotte in the Public Health Sciences program. Dr. Doolin is actually my dissertation chair. But I had a quick question in regard to the ways in which burnout impacts access to primary care, and if you all have seen that play out, or if you have come up with strategies to address that.
And touch on this a little bit just from the health system perspective. Burnout through the pandemic has been one of our #1 struggles, as well as recruiting, not just on the provider side, but also on the nursing side and just teammates in general. Even recruiting CMAs right now, even though we have an amazing partnership with our local community colleges, it's still just a struggle. And we had so many folks leave healthcare in general during the pandemic and have not recovered from that. And then, I don't want to speak for the provider on the panel, but think about how many things you're being asked to do and all the different things within Epic and within our electronic health systems. It's one more process, one more click. And so we're continually asking providers to do more when we're all short staffed. And so we're really trying to be intentional within our med group. We have some physician champions really leading a lot of these efforts, where they're focusing on the teammate and the well-being of the teammates and really looking at provider burnout and how can we support the providers, take things off their plate that they may not need to do, where we can have someone else in the practice do it. And I don't think anyone's come up with a solution, but for that overall, but it's top of mind, I think, of every healthcare system and practice and from the provider perspective.
No, thanks, Jennifer. I think you're right on with your perspective. I would say, I think the fee for service model of medicine is just, I can't believe it's still here, I was thinking, oh, surely that's going to change. I would say one of the solutions for me, and I see, I'm very fortunate I don't practice full time, and I see my colleagues, under the administrative burden, and value-based care is coming in, and it's just added another layer of administrative burden. But one of the solutions I see, mention that integrated care model. It's so much fun to work in a clinic with an integrated care model when it's a team. And we don't live in a system anymore where it can just be a primary care doctor and I know everything and do everything and you're lucky to see me. It's a whole different world now. We need a team of people working together. And honestly, I love it when there's a pharmacist there and a psychologist and a nutritionist, and I learn so much more and it's so much more fun and the patient gets better care. So if we could find new models that actually reimburse outcomes rather than, churning people through with a fee for service, I think that would make a huge difference. And, the other thing for me, like working in the community with people like Latin American Coalition, other community partners, it makes it a lot more fun. Actually, just getting out of your walls, being part of the community makes it more fun. So maybe we can find opportunities to get people out and, help them, survive the burnout from, the administrative duties.
Yeah, I love, I love that. Thank you so much. Burnout across the board, I think, is definitely an issue. Some of us have grown up in an environment where just work hard. The harder you work, the better you'll produce. And realizing that this team model and just a team model within the organization in general is so important. A team model in the clinical side, like you said, integrated, behavioral health. We're doing that, and having care managers too, to help with it, et cetera. All of us are doing bits and pieces of that, but also on the support side, the admin side too, working together as a team and not as individuals really helps to alleviate the burden and to also recognize that we can't do it all. We can't do it all at once. And I think many of us who go into this profession, we're really type A, type AAA, and having to know, and I like what you said, lean on our partners. I'm not going to go out and invest in a mobile vehicle if I could partner with the hospital systems who are willing to partner and help us so that we can also get out there. I'm not, I don't have to start a new program on my own. I have other community partners who can help to support us. So I think that, that teamwork, when you mentioned that, is so important. And even myself, leading an organization, I have to walk the talk, right? I can't just say, hey, you guys go home, take care of yourself. I have to do that. And I'm trying to be more intentional about that.
Mark, since you brought up healthcare financing, I do want to make a quick point because I think that's a big problem with all of this, right? Because right now people get paid for people being sick, right? And I think that's so Carolyn, on average, how much do you guys get reimbursed for a primary care visit?
Oh, God, like about $180.
Jennifer, how much does the average ER visit cost? Just ballpark.
Loaded question.
Average, just,
I mean,
it's gonna be at least 4 numbers.
yeah, I mean, I would guess if you're looking at total cost, I mean, I'd probably say upwards of 1,000. I mean, if looking at cost of care with overhead, different labs, diagnostics.
All right, one more example. Keela, how much does a community health worker get reimbursed for seeing a client?
Maybe $35. And that was gonna be my next point. So I was going to add that just like burnout is a healthcare crisis, it's also a public health crisis. And so when we think about value-based care and working as a team, we also have to understand that community health workers are serving and seeing between 75 patients a day. And so while the provider is you know, passing down these instructions. The community health workers are also expected to go out in the community and make sure that those clients are then following them. And so then you also have to think about the burnout that that community health worker is experiencing, not because they're just serving the client, but then also they're from that community themselves. So I, you know, identify with the Black community. If I'm serving someone that is also African-American and, you know, let's say they just was released from prison, you know, I have some family members within, you know, that was recently released from prison. I'm triggered, okay? And I'm serving a population that's triggered, that equates to, you know, an increased burnout that probably wasn't there before. So I think, you know, we have to also protect our community health workers as they're interfacing with these populations that are already so vulnerable.
Oh, good evening. My name's Arthur Griffin, and I have no healthcare expertise whatsoever. But I do chair the Public Health and Human Services Committee of the county. About a year ago, Dr. Washington and others made a series of presentations about health outcomes in our community. And several things caught my attention, data points. One, African Americans die prematurely more so than any other ethnic group or racial group. HIV, you have Black infant mortality, Black maternal mortality, et cetera. And I'm saying, okay, doc, I'm not a healthcare expert. What can we do? And we've had a series of meetings trying to get data analytics, so that we could be more intentional about our intervention. You call it the crescent. 30 years ago, it used to be called the wedge. We have probably 360,000 Medicaid patients, probably that will grow to maybe to 400,000 in Mecklenburg County. I'm told that there are normal barriers, and you certainly identified those barriers, Dr. Doolin, earlier. How do we get the data insights to be able to strategically use those scarce resources to go into zip codes, to go into census tracts, and be more intentional to address some of the health needs? Because on the tail end, when I'm talking to providers, they're telling me, Arthur, it could have been pre-diabetic that caused conditions in terms of delivery. So how do we get that in terms of treating? So getting data is what I'm most interested in. And Dr. Washington just indicated, just getting off the phone, talking to Betsy Tilson with NC Medicaid and having conversations with Jennifer and her team. How do we get those data analytics? So from a public policy perspective, in addition to the private sector nonprofit, that we could be more intentional in reducing those horrible outcomes for that population. Be interested to hear your opinion.
Sorry, I'm a little bit of a geek when it comes down to data analytics. So I started my career as an engineer before I became a doctor. And that's been my question all along. It's like, why don't we use the data to drive improved care? And, you know, the technology is there. It's not a technology problem. It's more of a people and process. And there's so many layers of protection around the data, which is good because you don't want the data to be leaked. I don't want my personal health data to be used in a way that would be untowards in some ways, but at the same time, there's so much value if we can integrate the data. And I think, you know, that's part of the idea of partnerships. You know, how do we all work together as partners so that, you know, we're comfortable sharing data? You know, it's a nice way of leveraging an academic partner. We're kind of a neutral person in the community that can, you know, hopefully handle that data in a safe way. We have the School of Data Science out at UNCC. So how do we, you know, leverage some of those components like the technology, the students, the partnerships, but do it in a way that is protective of the data, but at the same time does exactly what you said. Because not only do we need to identify the problem with the data, we need to evaluate what's working, because a lot of what we do in healthcare doesn't work. It sounds like it's going to be great. You know, let's deploy this new whatever and spend a couple $1 million and see what happens. But you really have to be careful and evaluate and see if the money that you're spending actually does make a difference and drives the right outcome. So it's a great question and one we should all be thinking about carefully. I do think policies are changing to make it, like I mentioned earlier, easier for us to capture data from electronic medical records. Jonathan's going to do that for us. I see it.
Whoever has the mic, the last couple of questions, because we are out of time.
Hello, good afternoon. My name is Brandy Foreman. I am a public health educator, CHW. Shout out to Keela. My question is, we love our seniors. However, there seems to be sometimes a lack of focus on them, especially with the rising cost of treating from dementia all the way up to Alzheimer's and getting long-term care and access. Is that going to be, or is it a new focus that people are starting to pay attention to? And then how do we, make sure that they're being, taken care of? I do outreach at the Tyvola Senior Center 2 to 3 times a month. And even today, a lady is on the verge of, being diagnosed with dementia. And so she's worried about what's next. And what does she do next? And unfortunately, her children are out of state. And then when she's calling around, resources are exhausted. And then, so that's one question. And the other question is, there's so many maternal health and women's programs. I love Atrium's Women's Drive to Thrive. I've worked with your mobile unit. It is absolutely amazing. But in terms of health equity, where are the men being focused at? Where are, especially for culturally identifying as African American, they have one of the biggest barriers in terms of trust. So how do they know where to go and get their prostate screenings and the screenings that needs to be done to do the preventive health to make sure the pre-diabetics don't get to that point? And so public health has a lot of amazing programs, but unfortunately right now our men are not being taken care of. And so where are the programs that we can help them to navigate to say, hey, hey, Mr. Arthur. Hey, Commissioner Arthur. You need how you doing today? And so we can help navigate our men to be taken care of as well. So be interested to know.
I can start and then others can add on. And the dementia care hits a little close to home. My grandmother is struggling with that now. And I know we talked about, aging parents and navigating healthcare. And between my mom and multiple siblings, and then myself and my husband, it took about 8 of us to get her into a new memory care site. So it is incredibly complex. And if you don't know all the rules about your spend down and when things kick in and what has to happen in your assets and what you do with a home, it is very, very complex to navigate. And you truly do need almost a hospital admission and an inpatient caseworker or social worker to help you navigate that. I had to call friends, get advice, ask questions. What happens when this happens? And I don't have a good solution for that as a whole on just resources that are out there, but definitely from the health system perspective or even CHWs, we always try to connect them back to a case manager if we can, or someone that has that expertise, or a social worker. But recognize how challenging that is, and it's incredibly complex. On the health equity side of things, and thank you for mentioning Drive to Thrive. Very excited about that opportunity. It's really one of the first in the nation just focused on women's care and not doing primary care and other initiatives. And from a health system perspective, in looking at our internal data as well as the public health data, have identified our biggest health inequities in across the country, but in the Southeast as well: cardiometabolic disease, which you referenced, and then violence-driven injuries and infant maternal health. And those are the biggest gaps in care among our patients, where we see the greatest disparities. And so looking at things like diabetes prevention programs, hypertension programs, and education, as well as a major focus, because the disparities are there and they're real, as well as the infant maternal that you mentioned.
I'll comment on the men real quickly as the lone man on the panel, which is just to say we're horrible at getting healthcare. And I'm probably even worse as a doctor. But I would say one of the major issues, so there is good data that shows if there's concordance in terms of race and ethnicity and gender between a provider and the patient, there's better trust and people are more likely to get the test that they need. And we're doing an awful job with getting African-American men into the medical field. And we need to do a better job with that. It's part of the pipeline, growing the pipeline, understanding that there are, just disparities in terms of that process and trying to make that different, because I think it would be, much easier to go in to see somebody that's like you, gender, the same gender, the same culture, to get the care that you need. So I think that's an area we definitely need to improve upon. I'm excited we have a medical school coming, so hopefully we can do that.
Thanks, Mike. All right, I'm playing master facilitator, but there are two people that have the microphone. So Dr. Scott and one of our lovely students, Aaliyah, you guys get 30 seconds apiece. Go ahead.
Okay, I'll be very brief. Kimberly Scott, Mecklenburg County Public Health. I wanted to talk quickly about Medicaid expansion. We know that we've expanded Medicaid in the state of North Carolina, and we're excited to see several folks having access to coverage, often for the first time in their lifetime. So I'm really curious to firstly direct this question to Carolyn. I'm thinking about the federally qualified health centers. Are there any unintended consequences that you're seeing with Medicaid expansion and things that we should think about to inform a policy agenda?
Thank you so much. Unintended consequence, staffing. Staffing, because we do have, we have outreach and enrollment workers, but we don't have enough individuals to assist our uninsured people to qualify for Medicaid so that they can be a part of that. It takes, I was told today, the process takes at least an hour, to go through. It's a long process to get people enrolled. And also, once you get individuals enrolled, Medicaid is experiencing a backlog. And so Medicaid expansion has been, it's wonderful, but it's slow rolling process. And also not all of patients that we serve, will be eligible, because like I said earlier, we don't ask if a person is documented or not. And if you're undocumented, you're not going to even try. And so we had to come up with another solution process to make sure that we continue to reach out to all communities to let them know, about, okay, if you don't qualify, here's something else, here's another avenue. But it is good, but it's really evolving very slowly. And it's not this big rush of, we have about 68% of our patients are uninsured. We're not seeing the needle move that quickly. And it just started in December, right before the holidays. So, but still, it's going to take a lot of effort.
Now, I have just two things really quickly. I know we're at time, but
It's quick, just 20 seconds.
so, yeah, 10 seconds. So one, I have the privilege of serving on the caring board, and you've got patients that have been in free and charitable clinics for a very long time. They've had access to free medications through formularies or programs like Medisys. And now all of a sudden there's a copay and they don't know where to go, and there are unintended consequences of costs that they didn't incur before. And so some patients that have enrolled, that were in free and charitable clinics, have now enrolled, and they're saying, well, now I can't get my medications, and these copays, when we talked earlier, $3 copay sometimes is a big deal to some. And so I think we have partners that we work with low cost affordable medications. That's one thing. The other part of this is the access and staffing. And so just because all of a sudden now you're in an MCO, you get on this list, about a third of the list we may have seen ever. Third may have been there in the last 12 months, and a third we may not know at all. And so you look at these, how do we get them in? Where's the best location? And then can they get, if they get into a primary care practice, is there a medication assistance program or any support services? So I think it's just the logistics of it all.
Yeah, excellent points, guys. Aaliyah, here's the final word.
Hello, I'm glad to be the last person. My name is Leah McKinney. I'm with the Public Health Department. I'm a recent graduate, and I'm applying for medical school this cycle. So my So my question to you all is, what advice would you give community members and pre-health students to get involved in population health and community education? You spoke about building a pipeline, and in my experience, being a pre-health student, being pre-med, is that it's difficult to even know that those pipelines exist. And I was fortunate enough to go to a school that has those pipelines built out. But as someone who's the first to pursue medicine in my family and to find those pipelines and to find those mentors, what advice would you guys give?
So I'll talk about the student education and learners just from a population health perspective and others. And before joining Atrium, came from an academic healthcare system in South Carolina, where when you were a year one medical student, you were trained as an EMT. And you worked on the ambulance, you learned community,
Thank you, Glenda.
and then you, and that's it. And, but then also looking at the way that we focus on learners, and can they be trained as community health workers or EMTs and get in communities? Can they come and work on, provide academic learning experiences on mobiles or going into homes? And that's something I have seen bring a lot of value to medical students in the past, and even on residents, to know what happens outside of the four walls of the building.
I'm gonna add
Yeah, no, please go ahead.
briefly. So I know that we are looking to explore how we can build pathways for not only public health, but healthcare as well. And I am a firm believer that community health workers is where it starts. So not only does a model exist in Atlanta, Georgia, Morehouse School of Medicine, they've done it. They've built a pipeline where they're training their high school students as community health workers, then employing them wherever there's a gap. So I do think it can be done. It's just finding a high school or organization that's ready to do something like that. And then from that, you know, there's already like CNA, like pathways and bridgeways that have been traditionally done. I think in terms of public health, considering that we have an aging workforce, aging and underskilled workforce, we can use community health workers to not only train them up to benefit and serve our community where community engagement is sorely needed, but then also, you know, they could be the next policymaker. They could be the next epidemiologist. I mean, look at me, I'm in, you know, my PhD program, and it's very possible that community health workers being on the front line, they know the concerns of the community, they know what needs to be done. So I think community health workers is the key.
Heather.
Can I add, I'm sorry.
Yeah,
Wait,
go ahead.
One last comment. I'm only thing between you and the reception, but I would say UNC Charlotte has worked very hard to do this, and hopefully you've seen that. They work with CPCC, they work with the high schools, the elementary schools, and really try to pull people from the community into, you know, to get their experience there. It's tough without having a medical school here now. Hopefully, you know, as that develops, we'll have those opportunities. But 40% of our students are first generation students, and our demographics are very similar to our community, which I'm very proud about. I mean, there's a lot of work doing that, and come talk to me. Let's see what we can do to help you get into medical school. I'm excited for you.
There we go. So I will say, and APHI is an example, and the academic health department model that we're building here in Mecklenburg County is an example of what we're trying to do here to make sure that students have an opportunity to be exposed to population health. So this summer, I think we have probably 20 to 25 high school, college students, if not more, with our environmental health folks. We have 50 nursing students, and Dr. Coyle's working on a partnership within the medical school to make sure residents can rotate in our clinics as well to see public health in action. So, and this is actually another example of why we're trying to create space for students to connect with us as public health practitioners and clinicians in the community. So with that, thank you all for being here tonight. I will see you the next time we have this. Enjoy the food in the hall. Thanks.